Hey guys, this is Dr. B and this is the second video in my Ace the PLAB series. Today we'll be covering geriatrics and palliation. If you're already familiar with this subject and you're lacking concept in certain areas, feel free to use the progress bar below to skip to the section in which you need to clarify some concepts. And without further ado, let's begin. Formal medico-legal documents. We'll discuss 4 medico-legal documents, namely the DNR or DNI, the Advanced Health Directive, the Power of Attorney, and the DS 1500. Now, DNR or DNI, basically they stand for Do Not Resuscitate or Do Not Intubate. These apply to situations in which the patient is pulseless or in an emergency which requires intubation. These documents can be issued by the patient willingly or by the doctor. It's done when CPR or intubation is not going to be in the best interest of the patient. We often would issue such DNRs in patients of palliation or in patients, for example, who suffered a cardiopulmonary arrest and a long time has lapsed, so the doctor suspects neurological deficit has already occurred. In such patients, it is wise to issue a DNR or DNI instead of going ahead with it. So if the patient is resuscitated, he may just be in a vegetative state. Now let's go on to the Advanced Health Directive. Advanced Health Directives basically are legal documents which spell out the course of treatment that the patient would like in the event that he or she is not able to consent or will become unconscious. Let's compare this to Power of Attorney for a second. Now, instead of this being a document, Power of Attorney is actually a person who's appointed to make decisions on behalf of the patient in the same scenario. Sometimes in the PLAB exam, you are framed with a question which says that a patient is mentally unstable or suspected to be mentally unstable and a Power of Attorney is present. So, what is the next best decision? Do you ask the Power of Attorney or do you ask the patient? The correct answer would be to ask the patient after a mental assessment and not go to the Power of Attorney just because he's appointed to. Preference comes to the patient before the attorney. The DS 1500. And the DS 1500 expedites the process of claiming medical insurance when patients are considered terminal. Often at times, it can be quite a long, time-consuming process to claim insurance policies, so DS 1500 helps in this regard. Informal medico-legal documents. Now this is important because often at times we have an odd patient who comes to the emergency unconscious or in some sort of emergency who requires treatment but possesses a note of suicide or intent saying that they don't want their life to be saved. Now, as a doctor, we need to be aware of 3 things. If the note is clear, if it's signed, and if it's witnessed. If a note possesses all 3 aspects, then do we accept it. If not, we reject it and we start treatment. The note is legally void in this regard. Pharmacy prescriptions. Now, this is pretty simple. A pharmacy prescription should always have the patient's name, his age if he's less than 12 years old, quantity of drugs both in letters and numbers. Now, this basically means you've got to spell out. So if you say 56 tablets of paracetamol, you must spell out 56 in its letters as well so that there's no discrepancy. And at the end of the prescription, a doctor must always sign by hand and not print it out electronically. Death certificates. The key principles we're looking out for is basically mentioning the cause and not the terminal event of the patient. Let's say that a patient has developed severe pneumonia and this has led to cor pulmonale and death due to heart failure. In this case, the underlying disorder would be the pneumonia and not the heart disorder. So, heart disorder is a terminal life event which we don't report. Another example. Person with breast carcinoma develops lung metastasis and then dies due to respiratory failure. Now the underlying cause is the breast carcinoma and not the respiratory failure, so that will be the cause of death. Managing pain. I've drawn a simple step ladder for you guys, starting with NSAIDs and then progressing to opioids on the second and third rungs of the ladder. Naturally, as we go up the ladder, there is increasing analgesic effects. However, it must be known that opioids possess certain side effects such as constipation and nausea. The rule of thumb is to go up the ladder if your pain is uncontrolled and the side effects are present. If pain is not controlled, increase the dose of the current medication. There's no incentive to be changing the medicine in this case. Let's go back and talk about NSAIDs. Now, NSAIDs are contraindicated in a few scenarios such as CKD, heart failure, peptic ulcer disease, asthma, and coagulopathies. This is due to the inhibition of the prostaglandin and prostacyclin pathways. In such cases, we give paracetamol to patients instead. Always remember that in pregnant women, you can only give paracetamol. The reason why is that giving NSAIDs may cause premature closure of the patent ductus arteriosus, which is supplying oxygenated blood to the baby. Now let's talk about if a patient can't tolerate oral analgesics. What other alternatives we have? We've got subcut, IM, and we've got patches. Now let's talk briefly about some of them. With intramuscular injections, patients with coagulopathies may develop hematomas, which require surgical drainage instead. So we've got to be wary if someone has a bleeding disorder. Patches, on the other hand, have a few downsides. They've got a long T half-life, so that means that they're only good if the pain is well controlled or stable. In cases of unstable pain, where there's spiking and lows, like let's say after a surgery, patches are not quite effective because we need to use drugs with a low T half-life to act immediately when required. Additionally, patches can also be influenced if the patient is sweating, which thereby decreases its absorption. I've left some pointers on this slide so you guys can address some specific scenarios in the PLAB. Dosing opioids. Now, opioids consist of a routine dose and a breakthrough dose. I'll give you the example of a prescription for 60 milligrams of morphine given twice a day. Now, to calculate the breakthrough dose as required by questions, we're going to have to first calculate the routine dose. The routine dose is 60 into 2, which is 120 milligrams for the whole day. The breakthrough dose can be even up to 6 times a day, so we're going to use a routine dose of 24 hours divided by 6, which we get 20 milligrams in this case. It's also important to understand that oral bioavailability is lower than if we had used subcut, intramuscular, or intravenous injections. So we must half the dose if we're using morphine, or 1/3 the dose if we're using dimorphine. For people who don't know, dimorphine is also known as heroin. This is the synthetic version of morphine. Calculations involving percentage ABV or percentage solution. Now, percentage ABV represents the units of alcohol present in a liter of drink. For example, 40% ABV means 40 units of alcohol per liter of that drink. Now, a little bit of additional information if you guys would like to know is that a unit of alcohol possesses 8 grams of pure alcohol. So in this case, we'd get 40 into 8, which is 320 grams of pure alcohol. Now, percentage solution is a little easier. We have 1% equivalent to 10 milligrams per milliliter. So if a person has 20% of a certain solution, that means 20 milligrams per ml of that solution. So let's say a person drank 10 ml of that solution. So we'd get 20 milligrams per milliliter into 10 ml, which is 200 milligrams of that certain solution. Managing vomiting. I've penned down a lot of situations in which you must control the vomiting, as well as the respective drug in each regard. Feel free to note this down because this requires straight up memorization. I'll explain you the mechanism of action in just a second. The most common prokinetics that were tested in the PLAB include metoclopramide, haloperidol, and the phenothiazines, which include levopromazine, prochlorperazine, and chlorpromazine. Now for the mechanism of action, these drugs inhibit the dopamine receptors present in the chemotactic area of the medulla oblongata. By doing so, they prevent vomiting. Ondansetron, which is used for chemotherapy, radiotherapy, or even post-op, has a similar mechanism of action. However, instead of acting on dopamine, it is an antagonist of serotonin. As with all the dopamine antagonists I have mentioned, if you ever get a scenario in which a patient has developed Parkinsonian type symptoms after taking a course of this drug, you must always look back and figure out if these medications are involved in his treatment or not. If they are, stop them. Managing hiccups. Now, hiccups can be classified as both central or peripheral. Central involves any head trauma, stroke, space-occupying lesion, or any other brain pathology. We give chlorpromazine for this case. Now for peripheral causes, we've got irritation of the phrenic nerve, which supplies the diaphragm, and irritation of the vagus nerve, which supplies the stomach. We'd be using metoclopramide in either of these cases. Managing neuropathic pain. Now we've got three drugs that we commonly use to treat neuropathic pain. We've got amitriptyline, which is a tricyclic antidepressant, gabapentin, which is an anticonvulsant, and duloxetine, which is a SNRI, similar to SSRI. However, this is a selective noradrenaline receptor inhibitor. We'd use these drugs, for example, managing the glove and stocking neuropathy of diabetics. Managing spastic patients. The two most commonly used drugs, which are very similar in efficacy, are baclofen and diazepam. Talking in retrospect, neuropathy, pain, spasticity, all of these are symptoms which need to be addressed. So certain medications, although they won't treat the disease, they'll manage the patient's symptoms. If you look at these symptoms for what they are, it's going to really help you in the PLAB exam, so it would be easier for you to choose the right answer. What is hospice care? Now, hospice care focuses on the palliation of the terminally ill. This means that in palliative patients or patients with poor prognosis, we can't treat the disease. However, we may maintain the patient's dignity and keep the patient at ease. Hospice care is up to the patient to decide whether he would like it at the hospital or at home. In cases where the patient chooses his home as a place for hospice care, medications are prescribed and sent in an emergency box. Now, these can be administered by a district nurse, whom is called to the patient's house for administration. Now, morphine is for the pain, midazolam is for sedation, haloperidol is used for treating systemic causes of nausea, and hyoscine butylbromide is present in the commonly known drug Buscopan. And what this does is that it manages thick respiratory secretions that may be clogging your airways. Often at times, we get scenarios in palliative patients where they are described as having a wheeze called a death rattle. Whenever you encounter death rattle in the question stem, always know that we manage it with hyoscine butylbromide. It's important to know that these drugs are administered subcutaneously. The reason we do this is to prevent aspiration when drinking fluids with oral medications. If a patient would like to self-administer, we may provide the patient with suppositories for ease instead of the district nurse being called upon for a subcutaneous injection. The last topic we'll cover is managing palliative bone pain. We try to manage this primarily using radiotherapy. If this is not available or the patient chooses not to, we may give them oral biphosphonates. Now, it's important to know that biphosphonates cause esophageal strictures. The precaution, as usually asked in PLAB scenarios, is to tell the person to drink an ample amount of water 30 minutes before a meal with this medication. So there you go, guys. This is all for palliation in geriatrics. Feel free to comment down below if you enjoyed the video, and if you'd really like to support me and not miss an update, consider dropping a subscription to the channel. So it's totally free and it only takes a second. Take care everybody and stay safe. My name's Dr.B. Later. Yeah.